Patients with serious illness frequently need pain management. That means opioid medications are being prescribed. How do hospice teams manage pain medications and the challenges that come with having them in the home? You're listening to Heartbeat from the Heart of Hospice. I'm Helen Bauer here with Jerry Fenter.
Whether you're a family caregiver or an end-of-life professional, we're here to enhance your hospice experience by connecting you with information you can use about end-of-life care. Because we know how busy life can get, Heartbeat is designed to give you helpful information in a bite-sized format.
We're talking about a controversial subject today. We don't usually do that.
Why is it controversial?
Oh man, people get a little bit crazy when you start talking about pain medications.
Well, that's true. And I suppose there is some controversy about it. We're going to talk a little bit about that here in just a minute. Some of the controversy actually occurs, however, because of lack of understanding about medications, about opioid medications.
Right, lack of information. So we're going to hit that head on.
Sure. Now, let's start by, first of all, reminding people that when we're talking hospice or palliative care in general, we're talking about always trying to improve a patient's quality of life. And so quality of life means that the patient's pain is being managed. Now, I'm going to repeat something that Barbara Carnes always says, and that is, death does not cause pain. Disease causes pain.
Right.
So what we're trying to do is to help the patient manage the pain that they have from the disease. So good pain control is very important to good quality hospice care.
So you know how everybody on the hospice team that goes to see the patient will ask the patient if they're having pain.
That's right, including the chaplain and the social worker.
And the aide and the volunteer.
Right.
Everybody asks. And there's a reason for that. It's because pain management, good pain management, is central to more than just physical comfort. If you think about what pain affects, it affects social interaction. It affects how they can manage their own personal care or participate in their personal care. It affects their mobility. It affects their appetite, whether they want to eat or not. It affects whether or not they can sleep. It affects every aspect of their lives.
Body, mind, and spirit. So
exactly.
Having that pain affects their mindset, how they look at the world, how they look at the people around them. I just know from my own experience with pain, and I don't have pain a lot, but those times when I have to say, when I'm feeling pain, I get really grumpy. And that's a nice way of putting it. I'm not a nice person to be around if I'm in pain.
Well, I've had terrible migraine headaches, and I can't talk with you. I don't like the sensation of touch. I can't stand light stimulation. I'm sick at my stomach most of the time, so I don't want to eat. If I can get comfortable enough to sleep, that's one of the things that helps. Pain really does affect so many aspects of the whole person. The whole person.
So good pain management is a way of improving the patient's quality of life. And so the best way to do that is with narcotics or opioids. So since this is really more your specialty, I'm going to be asking you a few questions about it, and we're going to let you do most of the teaching on this. So,
okay. And we know there are other medications, right, that manage pain, but our focus today is on narcotics, on opioids.
Right. So narcotics and opioids are the tools that hospice teams will use to help manage pain. And there are, again, other ways of managing pain, including even spiritual and social things that can help manage pain.
Oh, sure. Music therapy, all sorts of things.
Right. Absolutely. Absolutely. So there are challenges that come with using narcotics or opioids.
Right.
One of them that I have heard quite frequently is that people are afraid that the patient will become addicted.
Yes, they definitely are. People also sometimes think that hospice teams use opioids, especially morphine, to hasten death, to accelerate things.
Right.
which we do not.
Right. No, that's not the reason for morphine. Morphine happens to be a high-use drug in hospice because it does so many good things.
Right. It's very versatile, actually.
That's right. That's right. So that's one of the challenges, is that people are afraid of addiction. So we're going to talk about the challenges first, and then we'll talk about some of the things that the hospice team can do to mitigate the challenges. So first of all, the fear of addiction. Second thing is that there are some diversion concerns. So explain that a little bit more, would you?
Well, diversion, when you think of the word diversion, divert, basically means the medications don't get to where they're supposed to go. They don't get to the patient because they're diverted to someone else or something else. Basically means they're stolen by another person who is either going to use them or sell them. And we do see that quite a bit.
Basically, narcotics and opioids are sold on the street or something like that. And so here's the hospice patient who is getting these drugs for pain management, and somebody else is taking those drugs away from them and using them for less than excellent purposes.
Exactly. Yeah, we're always concerned with diversion. Our first priority is to make sure that patient's pain is managed. If the medicines go to someone else or somewhere else, then we have not improved that patient's quality of life by managing the pain. When you're planning your next event, keep in mind that the hosts of the Heart of Hospice podcast are available to speak at conferences and meetings. Whether you're meeting in person or virtually, we can provide education to your team on topics such as how to have compassionate conversations, how to recognize personal bias, building listening skills, and managing personal grief as a hospice professional. We'd love to encourage your team and remind them why the work they do is so important. Because we both have a personal hospice journey in addition to our years working in end-of-life care, we can also share a message of resilience and hope at your agency's next memorial service. To find out more, contact us at host@theheartofhospice.com. We'd love to be a part of your hospice journey. Now back to today's episode.
And then there's non-compliance. And again, explain what you mean by non-compliance.
Non-compliance just means that they're using the medication wrong. They're either taking too much of it because they have a substance use disorder, or they're confused about how they should take it. So they sometimes they don't take it enough, but oftentimes they take it too often. They'll take too much of it.
So maybe they forget that they've taken it and decide, well, I don't remember if I took it, so I'm going to take it again.
Exactly. Or they're not getting good control. And instead of letting the nurse know, over the past 5 days since I saw you last, I have had so much pain that I had to double up on my medication. When in fact, what we should have done was the hospice doctor would have adjusted the medication to a different type, maybe a higher milligram or an extended release or another medication, another drug itself, to try to manage the pain better. Or we would supply a medication that's used as a breakthrough pain med that can be used just as needed. So non-compliance basically means you're just not using it the way it's intended.
Okay, so that can show up, I suppose, if the drug is meant to be used over a 10-day period, let's say, and they use it all within 3 or 4 days.
Right.
That's a problem.
Right.
Yeah. Okay. So another challenge is the side effects that come from taking narcotics. So
yes.
Things like drowsiness. People who take narcotics typically become very drowsy, sleepy. They sleep a lot more when they're using the drug.
They can.
And the other side effect is constipation.
Right, which is always a concern when you take a medication that slows everything down because it slows your gut down at the same time. Another side effect that we get concerned about is that it slows respirations. It'll slow down how fast the patient is breathing. So that's one of those side effects that people get concerned about.
Okay. So now let's talk about ways that the hospice team can manage that, because the hospice teams are very adept at helping to manage using the pain meds when it's in the home. So let's talk about ways to mitigate that.
So the first thing we mentioned as a challenge is the fear and the misunderstanding that people have about using opioids, about the fear of addiction. So if a patient is truly taking a narcotic or an opioid for pain management, less than 1% of those patients are going to become addicted. It's
Really?
It's not an issue. It is not an issue. And it certainly is not our priority. It is not a priority in hospice.
So that would be one good thing to educate the family about, is that it's very infrequent that someone would become addicted to a narcotic.
Well, and I guess you could say, well, the patient's dying anyway. We're not concerned about that. That's a true but not helpful thought. And you would never want it to present it that way to someone, because basically it says we don't care about that. And actually we do. We actually do understand that patients have that fear and that misunderstanding. We want to address that. Our job as a hospice team is to listen to people's fears and not to discount them and say, oh, you don't need to worry about that. They're already worried about it. So what can I do to help you worry less? Thank you, Barbara Carnes. Knowledge reduces fear.
Right.
Teach them. Educate them. Let them know, I understand you have this worry. It's normal. Here's how I can help you to understand you don't have to carry that worry.
So morphine is one of those that they are afraid of, one of the drugs they're afraid of.
Right.
So tell us a little bit more about that. And we may need to do a complete episode just about morphine.
I mean, morphine is a great drug because it's easy to give. We can give it in numerous forms. It comes in extended release, tablets and things like that. But it also comes in a liquid, which we use small volumes to manage pain at the end of life. And one of the side effects of it is that it depresses the breathing. It slows the respirations down. So caregivers get concerned about that and think that hastens death. Even professional caregivers, sometimes in facilities, nurses that aren't familiar with end-of-life management and hospice philosophy, you weigh a benefit versus burden. When you have a patient that's struggling to breathe, you use the morphine even though you know it's going to slow the respirations down because it's primarily going to ease the respirations in addition to managing the pain.
That makes sense.
But I think morphine, people just have a misunderstanding of how it's used, and they just get concerned about it, and they think that morphine kills you.
And that's not accurate.
No, it's not.
Okay, so let's talk about how to mitigate non-compliance and diversion. So we're going to kind of throw those two in together because the way to mitigate both of them are very similar.
Right. It's got some overlap. So hospices usually fill all medications, for about 2 weeks, right? Our patients are not going to get a 30-day supply. We're not going to give you a prescription for 90 days. Our patients change so quickly. Their status can turn on a dime. A patient can go from being able to swallow pureed foods with medicines crushed in them to not being able to swallow at all and needing liquids or gels, things like that. So we will do a 2-week fill for medications. If we find that there's noncompliance, they're going through the medications too fast, faster than is safe for them, or medications are disappearing and we can't figure out where, diversion, we will fill for a smaller number of days, 7 days, 5 days. That's a great deal of work on the part of the hospice. It absolutely is. But sometimes it's necessary. Along with that, we will deliver the meds, pick the meds up and deliver them according to what state law allows and what company policy allows, and we will put them straight into a lockbox inside a home.
So a lockbox, explain that.
Just a box that either has a combination or some type of lock on it, and the only people who are able to get into that box is a responsible person that is trustworthy. Sometimes that's just the patient. Sometimes it's just a single caregiver. If you have someone coming in and out of the home that's doing the diversion, that's stealing the medications, then we will put medicines into a lockbox that keep them safe, secure. The responsible caregiver can take out the medications to be able to give to the patient, but it makes them inaccessible for theft.
Okay. So there are some other things that a hospice agency also might do, including something called a pain med agreement.
That's right. A pain medication agreement. It's basically a contract. It says, we expect the patient or the caregiver to disclose if there's a history of alcohol or drug abuse. We expect you to disclose if there's a history of vaping or tobacco abuse, because we consider that an addictive, that is an addictive behavior as well. We expect the patient or caregiver to disclose if another physician, another provider gives a similar prescription to the patient, if there's duplicate prescribing. It also defines the terms that the team will take if there's diversion or theft of the medications. And that can include discontinuing the medication. Going to short fills is one of those things, but then discontinuing the medication up to and including discharging the patient from hospice care.
So basically taking the patient off of a hospice.
Right. Letting them know that we can no longer meet your needs safely, so we will no longer provide your care. That is within the rights of a hospice agency to discharge a patient. We call it discharging for cause.
Yeah. So this is serious then.
It is.
Very serious. So what other things might an agency do to try to mitigate any non-compliance or diversion?
Well, a lot of times we'll do a risk assessment, pain medication risk assessment.
Okay, what does that look like?
It's a form, a checklist, a set of questions, and it helps to identify patients or caregivers where diversion or theft might be a concern. And it asks about a lot of different things, not just substance use history, but things like sexual abuse before the age of 14, the smoking, vaping, any type of tobacco use, all of that carries an addictive component. And part of the checklist includes whether this person is male or female, looks at age, things like that, family history of substance abuse, things like that. So an agency might do that as well. And if they're doing that, they should do that risk assessment on every single patient.
Right. That way there's no bias involved in it.
Right. Because the fact of the matter is diversion and theft of narcotics, of opioids, happens in the most well-to-do homes, the most educated families, as well as areas that are poverty-stricken where there's a high incidence of drug trafficking, drug sales. Right.
It really doesn't make any difference. The socioeconomic area does not necessarily matter one way or the other. So they will do a risk assessment then on all the patients.
Right. And I guess as far as mitigating non-compliance due to confusion or the patient getting confused about what doses to take and getting ahead of things, we do recommend an administration journal, a pain med journal, so that you can keep track. When did I last take this? How many did I take? Or what symptoms was I having? That's super important.
It really does make a difference to write it down.
Oh,
write it
sure.
down.
Absolutely it does.
I'm bad about forgetting things if I don't write it down. So
Right. So you can imagine a patient that's having a lot of pain issue, or a caregiver that's managing a lot of caregiving responsibilities. What time did I give mom that last medication? It's better. And that way, if the patient is taking routine meds and then they have to have breakthrough meds in between, if a caregiver or a patient writes all that down, the nurse can look back and see for the last 3 days, well, they've taken 6 extra doses of breakthrough pain medication. So we need to get something adjusted. I'm going to go to the doctor, talk with the doctor and say, this patient's had this many extra milligrams of morphine, instant release as a breakthrough medication. So can we look at upping the routine dosing? There's a lot that goes into that. So having an administration journal is really helpful.
Yeah, I'm getting confused just listening to all this.
I know, it's a lot.
It really is. Okay, so one last thing. We want to talk about how to control the side effects that come with taking narcotics.
Oh, every patient, as a standard, if they are receiving a narcotic, receiving an opioid, should also be put on a bowel regimen, because the struggle is real. Constipation is a problem. Maybe they won't end up needing it, but you definitely want to have it in there.
Right. It's always best practice.
Absolutely. Unless it's contraindicated by the patient's condition, say, for instance, they have Crohn's disease or ulcerative colitis, something like that, where a laxative would be completely contraindicated. Yeah, you want to have a bowel regimen in that house.
Okay. Anything else that we might want to add to this?
Oh, good heavens. Teach. And document. That's for our friends at NHPCO. That'll make them so happy. But yeah, lots of teaching, lots of support. And if they ask you once, that's great. If they ask you 5 more times, that's awesome. Answer it every single time. Write it down in words they can understand. Leave it in the home.
Thanks for listening to Heartbeat from the Heart of Hospice. I'm Jerry Fenter here with Helen Bauer. Because we know your hospice journey is 24/7, you can always find us at theheartofhospice.com. Subscribe to the podcast wherever you're listening and leave a rating or a review on Apple Podcasts.
To connect with us, you can send an email to host@theheartofhospice.com. You can also find us on social media. And remember, no matter who you are or where you are in your hospice journey, you are the heart of hospice.